emergency use of authorization for potential COVID-19 treatment, which is the remdesivir. Now the physician can be able to use the remdesivir for critically ill adults and children that are hospitalized. So it's not for everyone. So why there are lots of unknowns? So as I said, in spite of the 3.5 million, there are still questions in the adult population about treatment and protocols and all that. In spite they have been improving. However, in our neonatology and pregnancy and pregnant women, there is limited pregnancy specific data. So that's why there are lots of unknowns. So for example, there are lots and numbers of questions that are still to be raised. We know that several viruses can be transmitted to the fetus virtually, like Zika virus, like the measles, like the rubella, the chickenpox. Also some viruses at time of birth, like the HSV and the HIV and the hepatitis. However, respiratory viruses are not known to cause vertical transmission and be transmitted at time of birth. So these are two questions, whether the coronavirus can do that or not. We know that probably the transmission is person-to-person aerosol transfer or transmission. The other question is whether the virus is present in breast milk or not, and the mother can transmit the virus to the breastfeeding baby. Another questions on pregnancy. What's the risk of the virus on the pregnant mother? There is the risk for premature rupture of membrane. Is there a risk for preterm delivery? Is there a risk of miscarriage? Then we step forward. And what are the side effects of this infection on the fetus, whether it will cause fetal tachycardia, fetal distress? Is there any teratogenic effect of this virus? The effect of the newborn, can the newborn get sick from SARS or not? And an important question raised in the neonatology field, whether to test or not to test these babies. Finally, one important question regarding protecting ourselves as healthcare providers, nurses, nurse practitioners, and physicians. What type of personal protective equipment to use in the delivery room, in the normal nursery, in the NICU when we are doing procedures. So on the other hand, what we know, most of it from the Chinese experience. Number one, we know that the virus has not been detected in the cord blood, in the amniotic fluids, in the placenta, in the breast milk, or any other maternal samples. We also know that the maternal viremia rate is very low, it's only 1%. And this study has looked at 9 pregnant women with COVID-19 pneumonia. They tested these samples in 6 patients, and they found that all these samples are negative. So look at the numbers, only 9 pregnant women with 6 patients. That's why there is lots of unknown, and we don't know for sure. And however, the conclusion from this study, they said there is no evidence for intrauterine infection caused by vertical transmission. Another study looked at 38 pregnant women. And according to this study also from China, they said that there is no evidence that SARS undergoes intrauterine or transplacental transmission to the fetuses. From the fetus and the newborn side, what we know that the newborns can get infected right after birth. We know that most of them have less severe COVID-19 symptoms than older children and adults. However, we know that infants less than 1 year are at high risk for getting very sick. And this study from China, they studied 2,143 pediatric patients, 731 were positive, 86 infants were less than 12 months, and they found that 32% of the critically ill patients were infants less than 12 months. Another study, only 4 newborn babies showed that the newborn babies are susceptible to the COVID-2 infection. They have mild symptoms, and their suggestion that intrauterine vertical transmission is possible. Another study of 33 neonates, which born to mothers with COVID-19, only 3 neonates had symptomatic COVID-19. Another study of 10 neonates that showed that this was a positive COVID-19. They had fetal distress, preterm labor, respiratory distress, thrombocytopenia with abnormal liver function. And also from the study, they said that vertical transmission is yet to be confirmed. So most of them are convinced that most probably it is something that happens after delivery from aerosol transmission. So of course, because of lots of unknowns and lots of questions, the American Academy of Pediatrics, the Neonatal Perinatal Committee and the Infection Control Committee decided to look into data and information and came out with guidance on infants born to mothers with suspected or confirmed COVID-19. And this is to help us, the neonatologists, to how to take care of our babies, but also how to take care of ourselves. The interesting thing that this came out, I think, the beginning of April, and there was some changes in the middle of April. Most probably soon there will be changes as well. So before I go further into what's the AAP guidance, there are two, remember, we are neonatologists. We do lots of perinatal consult. We talk to mothers before delivery, especially preterm deliveries. The obstetrician asks us about several questions regarding to the fetus and preterm babies. And the most important thing that comes up is the question of steroids and the question of magnesium sulfate. And the Royal College Pediatric Child Health and the American College of Obstetrics still recommend that steroids to be given for patients at high risk of preterm birth within 7 days at between 24-33 plus 6 weeks. For the 34 to 36 weeks, they said that the benefit of steroids is not very high, so the risk of giving it to the mother is higher, so they don't recommend giving it for more than 34 weeks. Magnesium sulfate, they still recommend that magnesium sulfate be given for neuroprotection for infants less than 30 weeks. However, we need to remember that magnesium sulfate can cause cardiac and respiratory problems, so it needs to be taken case by case and depending on the clinical condition of the mother. So what's the AAP guidance? They will go through number of points that are very important for all neonatologists, and I will go through each one of them. Before I go, it's very important to remember for this AAP guidance, there are two important points that they considered. Number one, that infants born to mothers with known COVID-19 at the time of delivery should be considered that they are suspected for COVID-19. And this is for the protection of the physicians and the nurses and nurse practitioners. The second important thing, if I cannot test this baby, then this baby should be treated as if they are positive for the 14 days until they are cleared after 14 days. Okay, so let's first talk about precaution for birth attendance, which is the most important thing. You don't want to take care of your baby and then the next day you are in the ER suffering from COVID-19. So they divided it into two ways. The simpler one is the droplet and contact precautions. And usually this for cases if you are gonna just attend regular delivery for a mother that is COVID-19 positive, which is usually we say the gown, the gloves, the standard procedural mask and eye protection. Also need to remember that eyeglasses, personal eyeglasses are not considered as protective eye shield. However, now, if you are thinking that this baby will need resuscitation, you will need intubation, you will need CPAP or high flow nasal cannula, this is an aerosol generating care. So you need to step high your protection, which is you need to go to the N95 respirator or even a higher way of protection, which is what we call the airborne droplet and contact precautions. So that's for if I'm going to attend delivery. So delivery room management, it's very important. It depends on what's your policy in the hospital. For example, the policy in my hospital, we have to attend all cesarean sections and we have to attend deliveries for preterm babies, less than 35 weeks. So if this is your protocol, then continue doing your protocol. Maternal COVID-19 on its own is not an indication to attend. If it's a simple delivery, then there is no need to attend. Also remember that we are trying to conserve our PPE and to minimize exposure. So you can change your policy in the hospital. If the hospital, you should attend all deliveries, in this current time, we might need to change to, no, I will not attend all deliveries. I will not attend the cesarean section unless I'm needed. If the neonatal clinician are needed to perform infant stabilization, like as I said, resuscitation, then we will need to do step higher with our protection. So the next step after the baby is delivered, okay, what we're gonna do with the baby? In my experience, the case that I've attended, the nurse went in wearing the PPE, and then they took the baby out and brought it to another room where we took care of the baby, and then the baby was transferred to the normal nursery and separated from the mother. The question is this what we need, separation? So the separation will depend on several points. Number one, the clinical condition of the mother. If the mother is sick and then she cannot take care of the baby, then of course separation is important. If the infant will need resuscitation, intubation and all that, then we need to separate the baby to another room, because there will be many attending nurses, nurse practitioner, physician. So to minimize exposure, you need to separate. The other thing is testing. If the baby's test is positive, then there is no value of separation because both of them are positive. Some mothers will request that, no, I don't want to separate. I would like to room in with my baby and I will desire to breastfeed. Then you cannot separate the baby from the mother. Also, if the hospital does not have enough rooms to accommodate separation, then you cannot do it. And finally, if the baby is going home and will be with the mother, then what's the value of separation in the hospital? The most important thing, you will need to discuss all these points, risk and benefit of separation with the mother. Of course, the risk, we know bonding with the baby, we know that will affect breastfeeding. However, on the other hand, the benefit is to decrease infection to the baby. So all this will need to be discussed before delivery. If we decide that we're gonna do the temporary separation, then both of them will need to be in separate rooms. We need to, the healthcare provider will need to wear droplet and contact precautions, which is the standard mask and the goggles and the gowns and the gloves. If we are not gonna separate, then the mother should be 6 feet apart from the baby. We can use a curtain between them. We can put the baby in the incubator. However, we will have to teach the mother the face mask, hand and breast hygiene when she comes close within the 6 feet. Very important point in our newborn babies, once they are delivered, we need to bathe them as soon as possible to get rid of viruses that might be on the skin surface. So what's the recommendation for temporary separation? It depends on the organization. If you're gonna follow the WHO said no separation. If you're gonna follow the Center of Disease Control and ACOG, they recommend temporary separation. So that's what's happening in the United States in most units. If you're gonna follow the Academy of Breastfeeding, they said it's the mother's choice. If they are planning to breastfeed, then there is no separation. So it's for each hospital to decide which organization they will follow. Okay, so breastfeeding. It's very important to remember that there is a difference between breastfeeding contraindication and breast milk contraindication. So breastfeeding and breast milk contraindication, there are very few things that are not allowed, that you should not be breastfeeding. Number one is galactosemia. In the United States and the developed world is the HIV positive mothers, of course, which is different in Africa and other developing countries. HTLV1 and 2, active brucellosis. And if the mother is using illicit drugs and she's not in any program. All these are contraindication for breastfeeding and breast milk. But if breast milk is allowed, then like other diseases, like for example, HSV on the breast, there is contraindication for breastfeeding, but it's not contraindication for breast milk. Active TB is contraindication for breastfeeding, but it's not contraindication for breast milk. So you can pump and give the baby the breast. So what is our recommendation for breastfeeding in this outbreak? We need to remember that breast milk provides protection against many illnesses because of the antibodies it has, and it might give lots of benefits to the baby. We need to remember that it is the best source of nutrition for most infants, and as we know that the recommendation of the WHO and the AAP that exclusive breastfeeding for 6 months. Also, we need to remember that there was no study to date that showed the virus in breast milk. Okay, so the International Lactation Consultant Association recommend breastfeeding should continue. The Center of Disease Control, they are against breastfeeding unless the mother insists, but they are okay with pumping and giving the baby the breast milk. The WHO, they are okay with breastfeeding, and that's why they are with not separating the mother from the baby. On the other hand, if the mother is very sick and cannot breastfeed, they are allowed to pump and give the baby the breast milk. So also your institution or you as a pediatrician or neonatologist, you need to decide what is the risk and the benefit and what would you recommend for these babies. Then the next step would be talking about newborn testing and discharge. Of course, here in the United States, neonates should be tested for SARS-CoV-2. And if the test is not available, then you should not be testing. Or if it's a very small amount and you need to save it for more important things, then you don't need to be testing. The optimum time of testing, we should be testing at 24 hours of age and then repeating it at 48 hours of age, because sometimes the first 24 hours of age is negative, the repeat test is positive. If it's positive, it has to be repeated every 48 to 72 hours until exactly the same like adults, until we get 2 negative results. So to discharge babies in the NICU, also from the normal nursery, also you need to follow your policy and procedure in your hospital. Just regular, normal criteria for discharge. Some hospitals, for example, I work in 3-4 hospitals. Some hospitals, it's a 24-hour discharge for normal delivery, 48 hours for cesarean. Other hospitals, 48 for normal delivery, 72 hours for cesarean. So follow this criteria. And also before discharge, we need to do all the required care for this baby, hearing screen, newborn screen, cardiac screen, and circumcision if needed. So if the baby we tested and the test is negative, then the baby should be discharged to a healthy caregiver who is not positive and is not a person under investigation. If the mother is going home with the baby, she should maintain 6 feet distance. She should use mask and hand hygiene when directly caring of this infant until she's cleared. And how do we know that she's cleared? It's 72 hours, no fever, and 7 days from the last signs and symptoms, or she has 2 negative tests 24 hours apart. If the baby is going home and there is a person under investigation who was exposed to the mother, for example, or exposed to other, they should take care, should use the mask and hand hygiene, and also they should be within 6 feet of the baby. If they come closer, use the mask and high hygiene. And the most important thing, I wrote it triple: education, 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 how to protect the baby and how to protect themselves. So what happened if the infant tested positive but no symptoms? Usually home care is preferable. So you will discharge exactly the same as any other normal newborn baby. However, this baby will need to have discharge and frequent outpatient follow-up for 14 days after birth. And this should happen daily and should happen either face-to-face with the pediatrician in the office or by telehealth or telemedicine. And of course, the baby, we should follow the precaution to prevent infection from spreading to household personnel or household family members. So how to diagnose COVID-19 in the baby? So it's exactly the same like any sepsis and any infection in our newborn world. So you should, at least one of the clinical symptoms, if you have temperature instability, hypo or hyperthermia, if the baby is hypoactive, poor feeding and tachypnea, chest x-ray findings of pneumonia or a simple RDS picture, but then I have a positive history of exposure and all the signs and symptoms, then this baby will be diagnosed as a COVID-19. So if we decide that this baby will need to be admitted to the NICU, also remember the most important thing that as soon as possible, we need to bathe this baby to get rid of the virus. The baby should be in a single patient room if we are able to use separate rooms. But if the hospital is cohorting several babies of COVID-19 in one room, they have to be 6 feet apart. They need to be in a air temperature controlled incubator. And then look at the treatment. It's just supportive care, treatment of prematurity if the baby was born prematurely. Routine and respiratory management. For the babies with respiratory distress, the treatment is exactly the same as all our babies that have respiratory distress. So don't think that the baby has COVID-19. It's just a respiratory distress in this baby. So we will use the high flow nasal cannula, the CPAP, or intubation and ventilation. But remember, all these are aerosol generating procedures. So we need to be the airborne droplet and contact precautions, and we have available negative room pressures. The testing for babies, you can say, oh, I will not test, I'm not waiting for the baby to recover from the... Or the best thing about testing is that you can get rid of discontinued droplet and contact precautions and limit the people. And that's what every hospital is trying to conserve our personal protective equipment and try to decrease So the very important thing that, remember, admitted to the NICU, if the mother is positive, she should not visit until she's cleared. The person under investigation, like for example, the father or an aunt, and also she should not visit until she's cleared. So what do I need to know? This is the main points. Number one is low rates of peripartum transmission. We think most probably it's an airborne after delivery. Infant born to positive mother at the time of delivery, and if infant cannot be tested, should be considered that they are suspected COVID-19. The medical staff should protect themselves and use the appropriate PPE depending on what they're gonna do. If it's a simple delivery and exposure just to a newborn that I'm not sure, then it's the simple one. But if I'm doing any aerosol generating procedure, I need to be on the high level of protection. Neonates can acquire SARS-CoV-2 after birth. The separation of the newborn and mother is lots of questions depending on which organization you will be following and what's the final policy of your hospital. If we decide that there is no separation, the baby should be in an incubator, the mother should be at 6 feet away, and education about mask, personal hygiene, and breast hygiene. Sorry, hand and breast hygiene. The virus has not been detected in breast milk to date with all the studies, so breastfeeding and breast milk can be allowed, also depending on which organization you will be following. Testing, infant should be tested 24 and at 48 hours after birth. Positive or not tested should be considered as positive and should be followed as an outpatient if they are asymptomatic for 14 days. If they are positive asymptomatic, home care is preferable. There is no need to admit them to the NICU. There is no need to admit them to the hospital. Treatment in the NICU, there is no magic drug. There is no magic thing about it. It is a supportive care, exactly the same as we treat the preterm infant and as we treat anyone with meconium aspiration. Mothers who are positive and person under investigation should not visit until clearance. Of course, as we all know, when a disease that we don't know anything about and it is something new, prevention is better than cure. Thank you.
Thank you very much, Professor Ashraf, for this comprehensive talk. And I think what we need is that everybody will have, if you need any question, you just prepare it. I'll talk for 10 minutes, not more, about something we need to do in our place. Let me do the same. I will share the screen. What I need to say after this comprehensive review of what the mother and the baby need, I need you to think about, do you have any information in the countries about, or in the region even, about these kind of baby? As you said, maximum paper come 20 patient or 10 patient, 9 patient from China. Actually something to make you relax a little bit, what's called newborn naming. So now they started to name the baby by COVID for boy and the corona for girls, and lockdown again for boy. So you get baby COVID, baby corona, or whatever, and they are actually, all of them are safe. So this is what's going on as a part of the change as usual. So what do we have in our country is that we actually get the information about the babies, newborn baby affected, whether the mother infected or not, from the media. So you get, this is the first case, come from April 6. This is the case number 1, COVID infected mother, baby first newborn. Number 2, this is another case, which is the baby preterm and the mother was positive in quarantine, and actually the baby died, and we don't know that whether this baby died because of the prematurity complication or because of the COVID-19 complication. Then you get 2 babies, 2 twin babies. Twin babies come from another mother, so this is from April 13. And this is the 5th case في another hospital, quarantine hospital in Kafr Zayat in 16 of April. And the last one, actually it come from a community infection where the حفلة السبوع, you get about 30 person come to the baby celebration of the new baby, and the baby has the disease by the age of 35 days. Again, the concept of registry. Many registry already started to develop. American Academy of Pediatrics section on perinatal medicine start a national registry. and also pregnancy coronavirus outcome registry, European Society of Pediatric and Neonatal Intensive Care Registry, and the infant surveillance and the maternal surveillance in UK. So actually, what we need to do is to open a perinatal COVID case registry, which will be hosted by Egyptian Neonatal Network. And like anything, you get baby might be born in your place or come to your place from another hospital. And then you have the data, so you need to feed this registry of the patient data, and then you continuous to have this data collection, and then we are going to analyze what's happening and reporting what we have. The objective of this registry is to provide a continuous update of the number of cases of COVID-19 infection among mothers who deliver at the country, also to study perinatal transmission from the mother to the baby, and also the possibility of postnatal transmission of COVID-19 from mother to the baby, to identify risk factor associated with that transmission, and to assess degree of severity in newborn with COVID-19 infection and risk factor for more severe disease if it's present. Then detect the outcome of infant with acquired COVID-19 infection, whether improved, died because of this, and then collect the infection control procedure present in the hospitals where the mother and the baby are cared. I think Prof Ashraf has already defined some cases, but at least if for inborn infant, if the baby born at your hospital, pregnant woman who has virologic testing positive for COVID-19 within 14 days before delivery, or admitted as a suspected case and whose pre-delivery testing obtained through 72 hours after delivery reported to be positive. And her infant also the same baby positive. For those outboard means baby delivered outside your place and then transferred to your institution. The mother has virological test positive for COVID-19 obtained 14 days before and through 72 hours after delivery at an outside hospital, and her newborn who is transported to your hospital for a higher level of care. So both, this is a kind of either inborn or outborn infant. Again, you can, I'll show you what we need, that from any computers, any laptop, so you can have a special application, you can download it, and you just report a case. You suspect, now in a month's time, we get only 5 or 6 cases. So we don't know in the coming 2 weeks or 3 weeks how many cases will come. What we need is the perinatal data. The perinatal data come from maternal and the pregnancy, her COVID status, complication, medication, and discharge. I think Professor Ashraf has talked about a lot of the medication needed for taken by the mother and its infection and all. Deliveries, mode of deliveries, and support, respiratory support or outcome come to the baby in the delivery room after maybe the baby comes stillborn or the baby died in the delivery room. Then when the baby is still alive, we need to have the admission data, NICU data, and respiratory support, how is feeding, like breast or not, discharge, what is the condition of discharge, and of course his COVID status. Again, simple lab result plus COVID specific, so you get CBC, AST, and CRP, plus I'm sure chest X-ray, something like this. So this is an example of some neonatal data. We need to have it. It is just to have like gestational age, birth weight, very simple data. You can have it and write it down. And this is, again, this is a discharge data for the patient, whether the patient have patient discharge home or transferred to other facilities or dead. And again, we'll be asked about the cause of death and a lot of information. Don't look at how long is this sheet, because actually what happened if the baby died in the delivery room, so you want to go to the discharge sheet. So it won't take more than 7 to 10 minutes to complete the data. Delivery room data, again, like APGAR score, mode of deliveries, and type of infant isolation, and the infant isolated in the hospital, and again, the location at which infant was cared for the hospital. Some example of maternal data, gravity and parity, and so on. We host this registry in our place in Egyptian Neonatal Network RedCap. So we will give you a password to log in and enter your data. If you have one case only, we appreciate to have it. So if you are interested, we need you to contact us. This is my email, and this telephone on a WhatsApp application, so you can contact us for this one. I nearly now finished, and it is the floor come for some questions for Professor Ashraf, and if you want to direct any question for me, I will be happy as well. Just if one need to have a question, what you need just to open the video if you like, or just you have an application of raise your hand, the action here, so you can raise your hand like you can raise your hand in the screen. So whatever you want. Any question, we appreciate it. Thank you very much.
I've seen one question about if there is a special investigation that give us a clue if baby infected, like what is done in adult like D-dimer. I think it's on the chat from Dr. Fatima. And my answer is, I don't think there is specific test that we do. We do our routine when the baby enters to the NICU, we do our routine. If we are thinking of a viral infection, we do liver function or complete metabolic. We do our chest x-ray, we do the blood culture, and even sometimes you are not sure whether it's the viral COVID-19 or other thing, you might need to put the baby on prophylactic antibiotics like AMP and GENT. However, we don't recommend antibiotics for every baby. You need to take case by case. But when a baby is admitted to the NICU, you need to do a routine management of any baby admitted to the NICU. Specific blood tests, I haven't seen anything specific for coronavirus.
Any more questions? Professor Imam Badran says, how you manage the baby if exposed to COVID positive healthcare worker?
So this will be considered as a nosocomial infection. Usually for us now, any person admitted to come to the hospital, we measure the temperature. We close all the doors for all the hospitals, and there is only one door available to enter the hospital, even if the hospital is huge. And everybody going through this door will be history taken, temperature measured, and risk of, or has he been exposed. So it's very unlikely that we will have cases like that. But we had our pediatric surgeons were positive. So what we did, we tested all the babies that he had contact with, and once they are negative, we do nothing. But if we are suspecting, they will need to be considered as personnel under investigation, and they will need to be watched for 14 days, and the healthcare provider should use the PPE.
Okay, thank you. You got some question asked about if there is any some sort of resources, so we can provide it to the group. If Dr. Ashraf, I mean, the recording of the lecture will be available, so we'll put it in the site of the Egyptian Neonatal Network. But I'm talking about the any other resources like guideline or something Professor Ashraf can provide.
Yeah, I will try to find. There is nothing, because things changes very quickly. I've asked for my hospital even protocol, and they told me things changes every day. So there is nothing written so far. but I will try to find, if I find something, I will send it to you. I've seen that Dr. Mervat Hashim is asking first, how are you, Mervat? I've seen that she's asking about the Survanta. So as I said, it's a routine management. We give surfactant. We are not using any of the drugs that have been used in the adults. I mean, there is no evidence now that chloroquine works. We use antibiotics only if it's a rule out sepsis, but if we are sure it's a COVID-19, we don't use it. So we treat the preterm as a regular preterm. Like, for example, in adults, there is evidence that early intubation is better than waiting. In the newborn world, there is no evidence that early intubation is needed. So we use our routine. If we need high flow nasal cannula, if we need CPAP, if we need in and out surfactant, we just continue to do our routine management of these babies. It's exactly the same like using steroids for the pregnant women for delivery. So nothing has changed in the routine regular management. Yes, no chloroquine, and we manage as a late neonatal sepsis. True.
Okay. Any more question? دكتور عيسى سلطان، مرحب بك من السعودية.
اهلا وسهلا، جزاك الله خير. الله
يسلمك. اهلا بك دكتور عيسى.
طيب يا دكتور، كيف حالكم؟ طيبين؟
الحمد لله رب العالمين.
تبارك الله.
والاخوة من العراق طبعا. في اي اسئلة أخرى؟ Okay, I'm asking, is there anyone interested in to join the registry within in Egypt, or we can have combined with the region? So I will be very happy to share the information and we'll get contact with them on a personal communication. Dr. Ghassan, أهلا بك.
I think there is a question from Dr. Iman Badran about how you define healthy caregiver. So with the questions, the screening we do is the temperature, then we ask about exposure or travel, then we ask about sore throat, runny nose, or coughing, or respiratory distress. If all these are negative, the healthcare provider is allowed to go into the hospital and work.
We still have some place to other question if you need. 5 minutes more.
We don't test the caregiver unless if there is any signs and symptoms, then we send them, we let them go home, be tested. But it's sort of a triage screening verbally, and plus the temperature.
Okay. So
we don't have screening for every mother going to delivery. Also, it's exactly the same. For the physicians, maybe there is one door that go in, but all the other patients and visitors, they go through one door, one entrance, and through this entrance, they are screened. If there is high risk, we test them. If they are not high risk, we don't test. I'm not sure whether they will be going into universal screening. There might be talks about that, but for now, no universal screening.
Okay. Okay, at the end, I would like to thank Professor Ashraf Hamdan for his very interesting talk and response to our invitation. And we need to be repeated maybe in a month's time where the condition has been changed, what's going on. And also I need to thank all the audience and thank the hosting for the hosting office, which is the National Erasmus office in Egypt. He are hosting our meeting, and this is the first Zoom meeting, and maybe sooner we'll have another one, and we'll invite everybody for this. Thank you for your attendance, for the people from Egypt, for my friend from Arab countries, and I see we wish you رمضان كريم وكل عام وأنتم بخير. شكرا لحضراتكم، شكرا دكتور أشرف، شكرا للجميع، شكرا.
Thank you so much. Thank you.
شكرا.
Good to see you.
Sorry.